Hello everyone, my name is Carly Use, and my final project poster that will be presented to you today will be covering PPE and equipment shortages and usage related to COVID-19. In order to understand the problem at hand, we must first look back at what brought us to this point. Through my research, it was made aware to me that there were several events centered around PPE in our lifetimes. For most of us, this all began in the mid to late 1980s when HIV was identified and the CDC released guidelines for healthcare workers to protect themselves. Our next main event was September 11th, 2001, when concerns were again raised that there was an insufficient amount of PPE and equipment left for healthcare workers and they were left vulnerable to exposure to bioterrorism toxins and other potential health concerns. Fast forward to more recent times. In 2014, the importance of proper use of PPE was again making headlines when two nurses caring for a patient with Ebola virus were infected, and studies were starting to show that global PPE shortages were a major factor in infections and deaths of healthcare workers in West African countries. During the time from 2014 to 2019, multiple sources were warning of the possibility of major disease outbreak and also mentioning that most governments would not be prepared. Now to COVID. By December 31st, 2019, several cases of pneumonia of an unknown etiology were detected in Wuhan, China. By the 5th of January 2020, the CDC National Center for Immunization and Respiratory Disease activated a center-level response for the novel pneumonia of unknown etiology. On January 20th, 2020, the U.S. had confirmed its first case of COVID-19. By early March, the World Health Organization stated that the price for PPE had at least doubled, with some equipment being sold for 6 times the amount. By the end of March, states began bidding against each other for supplies, and the WHO Director General said that the chronic shortage of PPE is one of the most urgent threats to our ability to save lives. What contributed to such a shortage of PPE besides demand? And what financial and regulatory implications did this have? Budget models in hospitals' operation systems valued minimizing cost over holding adequate stock of PPE, which was also due to OSHA's mandate that employers cover the cost of PPE and that PPE was not billable to insurance companies. The federal government was also unwilling to invoke the Defense Production Act, which would have required private companies to manufacture PPE. Issues with the global supply chain were also a factor, with the Chinese government restricting PPE exports, while they also owned a large amount of the supply chain for PPE. What did this mean for the quality of care? Nurses were reusing masks, respirators, gowns, and other PPE far beyond recommended manufacturer stated usage, as well as the National Institute for Occupational Safety and Health recommended usage because of low or no supply of PPE. Alternatives to N95s and surgical masks were introduced to the public, and healthcare professionals including cloth masks, which would have been shown to have the highest transmission rates among masks. A shortage of ventilators turned ICUs into triages where it could be decided who lives and who dies by who gets a ventilator, and some ICUs had to resort to ventilator sharing. Telehealth use also skyrocketed because of the need to limit face-to-face contact between practitioners and patients. How did this affect our organization, and how did it influence the shortage? Telehealth use again increased during the pandemic, both inside the hospital and in primary care settings. Staffing crisis caused major increase in travel nurses and travel nurse rates, further lessening the hospital's profit and eventually causing Congress to get involved, leading to the National Nurses March in Washington, D.C. during Nurses Week of 2022. Changes to organizations need to be made in terms of how PPE is used and purchased. If nurses do not have adequate PPE to take care of patients, not only does it affect the safety of nurses, but it also jeopardizes the safety of our patients. Therefore, hospitals need to investigate the amount of PPE available when staffing units and admitting patients with communicable diseases, rather than just staffing alone when admitting patients, which is now the common practice. The problem of PPE and equipment shortages opened up several opportunities for communication, which included many hospitals sharing updates on PPE amounts, which allowed staff to be a part of the discussion about supplies. Regular meetings with staff members were held in many hospital systems to discuss concerns, staffing issues, and available resources to staff for at work and at home, which allowed staff to also give feedback on the situation and provide recommendations for future implications. The PPE shortage gave a lot of nurses a look into the management side of the hospital systems, which is often not seen to the bedside nurse because of differing roles. Nursing during the pandemic had to adopt Marilyn Ray's theory of bureaucratic nursing. Dr. Marilyn Ray's theory of bureaucratic caring has broad implications for increasing their knowledge of caring, improving the health and well-being of patients, and changing healthcare organizations by shifting from a narrow to a broad focus where management and caring views can coexist and benefit the patient. With Dr. Ray's nursing theory in mind, where do we go from here? COVID-19 was not the beginning, nor will it likely be the end of PPE shortages. We must continue to learn from the accomplishments and mistakes made during the pandemic. It is important for our nation and our healthcare systems to not only learn from what has happened, but to make changes in order to prevent a repeat of downfalls. Suggestions for future implications include changing the way that institutions look at PPE, order PPE, and manage supplies because profit motives do not work in a healthcare system because markets fail to align with the interests of the people involved, in this case, our staff and our patients. Making sure use of PPE is warranted and appropriate for the task to minimize misuse and overuse of supplies. Reducing the reliance on foreign countries for manufacturing PPE and incentivizing PPE production in the United States. Improve the federal government's ability to coordinate, supply, and distribute PPE to hospitals, local governments, and state governments. And lastly, improve the enforcement of OSHA's regulations around PPE, including mandating that employers not only provide employees with PPE, but that it is also the correct size for the individual. Our world has forever been changed by COVID-19, and our healthcare system is still feeling the strain of such a large pandemic. I believe we will continue to see changes in our healthcare system in a variety of ways, hopefully for the better for not only our patients, but also our nurses, doctors, and other staff.